Good morning. So it's 10 o'clock. I suppose we'll start. Okay. So my name is Yusuf Guled. I'm coming from St. Elizabeth Medical Center in Boston. I'm trying to stay with the program. I don't know if there was an introduction or not, but I'll proceed with my talk. So I'll be talking about biologics, but I'm using the Dupixent or dupilumab as an example. We'll talk about its use and is it a game changer? Is it going to change the way we take care of chronic sinusitis with polyposis? Disclosures. These are my disclosures. Introduction on chronic sinusitis. It's a very common condition in the United States, in the West overall. It comes in two types, the chronic sinusitis with polyposis and without. These are two separate phenotypes, and the chronic sinusitis with polyposis that we're talking about is mostly a Th2 driven condition. And it's a difficult, we all know, difficult condition to manage. Symptoms usually come back even after surgery. There's usually maintenance. It's worse for aspirin-sensitive patients and allergic fungal rhinosinusitis. We have maintenance, which is usually topical steroids, sometimes systemic steroids. It comes in sprays, irrigations, and recently exhalation delivery system. Again, it's a Th2 disease. The treatment targets are usually IL-4, IL-5, IL-13. There are two other interleukins that are being researched on, but I'll focus on those three at this time. Medications that are available for the monoclonal antibodies for this condition are Dupixent, which was the oldest. It's an IL-4 and IL-13 target. Omalizumab, which is an Ig blocker. Mepolizumab or Nucala has been for IL-5, and benralizumab. This is a list of the medications, their use, and as I've noted here, dupilumab was the first one to be approved in the United States for chronic sinusitis with polyposis. This is just a infograph on how they work. Dupilumab is for the IL-4 and IL-13. You have mepolizumab is for the 5. This is a Th2 inflammatory cascade. And you have further downstream omalizumab and benralizumab. The indications in the U.S. For as far as ENTs are concerned, it's an add-on maintenance for poorly controlled chronic sinusitis with polyposis for over 18 years old, and asthma is an add-on for eosinophilic type disease. I think it's for age 6 and above. As a comparison, in EU is a little more restricted. You have to show all these things, and I'm mentioning this because some insurance companies now require this. Evidence of type 2 inflammation, evidence of systemic use. For most of the chronic sinusitis patients with polyps, this is easily reached, and all these other symptoms, including loss of smell and comorbid asthma. So why I'm talking about dupilumab today is because it's been longest in the market. As I said, it's an add-on maintenance. There are several studies talking about its effectiveness in comparison to ESS and its close comparisons. This is one of the studies comparing dupilumab with other available monoclonal antibodies for chronic sinusitis with polyposis. It's a meta-analysis, network meta-analysis comparing randomized controlled trials for biologics. And as far as efficacy in terms of nasal polyp score, it's not sinonasal outcome test, sense of smell. The dupilumab was better than the other two, omalizumab and mepolizumab. This is, again, another study comparing the four. This is from China, and putting together about almost 2,000 patients on all the landmark studies for monoclonal antibodies. Again, the nasal polyp scores was better, SNOT-22 was better, and over the 48 weeks of follow-up, dupilumab was better than the other monoclonal antibodies. This is an interesting study comparing treating patients who have not a lesser, small size of polyps, the TPS total polyp score of less than 4, and total polyp score over 5. And this was done in Italy. It shows that the improvement is the rate of improvement and the amount of improvement is the same for small polyps and big polyps. Basically, it's almost like a way of using dupilumab for almost all comers, with and use or not using topical steroids did not change the outcome. So here we have to add onto the topical steroids. This was a study done without and compare the difference. So, and the next is comparing dupilumab with surgery. This is a retrospective studies, which is March cohort. As you can see, both groups had about the same. There's no difference in SNOT scores. Patient who had FES had better polyp burden control, but in terms of extranasal SNOT domain, they had better olfaction scores. All the other symptoms, cough, postnasal drip, and thick nasal discharge was better. Again, this is a retrospective study. So the question is, do we need to do surgery for these patients? Does anybody start monoclonal antibodies for patients with big polyps without, doing any surgery? How's that working out? It's not consistent? Yeah. Okay. Mm-hmm. Okay. Any other opinions? Yes. And again, your cohort didn't find the whole picture. Yeah. Depending on PH1, PH2, PH3, your competition. Yeah. There'll be some failure rates for yeah, I'm doing that on purpose just to get, yeah. So surgery would be indicated in certain cases. Okay. In New York, sometimes we give biologic for polyposis as a surgery. Yep. Yep. Okay. Some of the non-surgical colleagues who taken care of asthma patients do, I get referrals from pulmonary. Sometimes people are already on biologics, but they still have nasal symptoms. Actually, I get a lot of usually also from sleep doctors who have patients with asthma on biologics already. They come in for nasal obstruction. So this is one of those patients. This is an 18-year-old who was about to graduate high school, is going to college. He came in mostly because nasal obstruction, he was snoring, he had some sleep apnea type picture. He has had turbinectomy, turbinate reduction as a child. He had a adenoidectomy, and during the surgery, he was noted to have polyps. The otolaryngologist at the time told him that he might need surgery when he's older. He had portions of smell. The teenager doesn't really notice it, but his parents do. He was seen by an allergist. I think they would discuss Dupixent, they're gonna start him on it, and then they came in for a second opinion because of the obstruction issues and, is he gonna be on this for the rest of his life? So his exam, he had a, total polyp score of at least a 5, he had a 3 and a 2, and this was his scan. He does have, he has concha bullosa, he does, significant obstruction and massive amount of polyps. Looks like an AFS. Any opinions? Yeah, so we planned, I didn't discontinue the Dupixent, but we planned surgery for him. And he did great. He actually went to college, and he was on budesonide rinse, and then he switched to nasal quart. He was not very consistent with the injections, and he did fine. We'll see what happens. It's only been about 7 months, 8 months. So, I mean, as far as reducing the polyp burden, there's several studies that shows that you get the biggest bang for the buck when you do surgery, when you reduce the polyps. You can address other obstruction issues, including if there are some other anatomical obstruction. You facilitate, effectiveness of topical treatments. And for, some patients are not compliant. The young people, they might not do the injections. They might fall off the wagon. You get better outcome when the polyp burden is reduced. And if you stop biologics, symptoms come back. However, there's role for biologics for sure. And, in terms of making a decision, some patients don't want to have surgery. So there's another option you can talk about and allow for medical management if surgery is contraindicated. If there's, patients are already asthmatic and poorly controlled, there's definitely a role to continue biologics there. And in terms of costs, there's several studies showing that biologics are quite expensive. If you, this is a cohort study, with a 10-year horizon. They use this Markov model. It's a little bit complicated. Shows if you have all comers here, and they split into 2 groups, and what are they, here you have somebody going all the way with biologic, and here somebody can go through surgery and different variations. At the end, the cost of doing surgery is much less. They use this QALY, it's called quality adjusted laugh here, which is basically 1 QALY means a perfectly healthy year of 12 months. If you have, that's 1 QALY. If you have 6 months, that's 0.5. So you have about the same QALY you get, it's about 10 times as much to use biologics. This is another study, again, with a 36-year horizon. It's a little more complicated, but again, they compared the patients who were treated in the Sinus 24 and Sinus 52 trials, and they use SNOT as a utility score. And again, the overall cost for the same amount of improvement quality of life is almost 10 times. In order to get to the same amount, for somebody who's relatively young and healthy, it's quite a lot. It has to go down by almost 97% to get the same benefit per cost. So some of the other questions, again, we treat a lot of patients with biologics in our practice. When we get these questions often, when do I stop? Some people have been on it for 2 years. They're doing great. They say, can I stop? Sometimes we have coverage issues where you'll have one insurance this year, they change a job, and the next insurance says you cannot use this anymore, or you have to use something different. And we've either have to fight or we have to change and see what happens. And I haven't had any problems converting from Dupixent to Xolair. Sometimes we have to do that. And if you have ineffective coverage, for example, somebody's on mepolizumab or he was on a Dupixent and they're not getting the effect, and you could change. And I usually try for at least 3 months or so to see if they're getting any benefit. There's some questions about adverse effects, known and unknown. So far, most of the advertised, besides arthralgia, I haven't had any bad side effects from the use of these. So thank you. Any questions? Yeah. I think so. Yeah, but it's a little complicated. There's weight involved. There's a little more to it than just Dupixent. Yes. I think the price came up after indication for chronic sinusitis and polyposis. Go ahead.
Just a comment. In our practice, we started to use Dupixent for people with moderate, but not necessarily obliterative polyposis, in conjunction with minimally invasive office procedures.
Yep.
And we're getting results on par with what we have in FES. And if we keep these people on for a period of time post-procedure, we're getting better results in terms of return of smell than we were getting when we were just doing FES before the biologics were available. And so it's really become front line. And then the bigger issue is the coverage issue later, because you have to keep showing the polyp score to get renewed.
Yep.
Dupixent. Well, you just remove the polyps, so they don't have a polyp score. And so we've had people go off because they had no choice. And out 1, 2, now we're out to almost 3 years with some of these people. Really, really good results just using nasal steroids. So I think maybe we'll end up being somewhere in the middle where it becomes an adjuvant to surgery, or you can limit the amount of surgery if you have a patient that's hesitant to have FES, or you want to do something more limited. But it's more than just putting them on Dupixent alone without any. At least you're debulking or getting rid of the tumor load. So that's really what we're doing a lot of now, and it's usually working. But there's no studies out there. Dupixent. There's no studies that really have any that I'm aware of that show the role of surgery and Dupixent versus the role of Dupixent alone. Unless you know something or there's something out there.
Okay. Okay. Go ahead.
I just want to also make a comment about adverse effects. When you downregulate the cytokines, like the IL-4, IL-13, you then can upregulate some of the Th1 cytokines.
Mhm.
So we have seen individuals that if they have other autoimmune diseases,
Mhm.
that sometimes you can exacerbate those diseases by using biologics. And so we're really becoming much more careful about looking at comorbids in patients, because some people will have severe adverse effects more than what is described in the literature.
Have you had any patients who have other biologics for other things, who we have some of those?
Yes, we have had that. And so when we have had to discontinue anti-IL-4 and IL-13s, we find that anti-IL-5 sometimes, for people that have other autoimmune diseases, they tolerate it better, and it doesn't upregulate like IL-17 and some of the other cytokines with their other existing disease processes. So.
Okay. Thank you.
So Spencer and Mark are going to now discuss this topic, which is again the particular question of the cost of this drug and those things you have, gene surgery, reserves,
Yeah.
Yeah, it's an interesting concept about the biologics and exacerbating other disease before we get into this. But, I have several patients previously who had been on Humira or other TNF-alpha inhibitors, and their polyps and their nasal symptoms would get worse right after their shot. And so, I had one patient who eventually progressed to a Lothrop just to get him under control because he couldn't come off his Humira for his rheumatoid arthritis. So, it goes in both directions since you have to look for it. And, in terms of that type of thing, it's like last week I bit the bullet and wrote my first prescription for Restasis to manage the ocular symptoms of a patient who was, on Dupixent. So, it's if we start getting into these things as otolaryngologists, we're going to have to learn how to treat things we never thought about before. So, that being said, our assignment was to piggyback on the preceding lecture and talk about how it's changing our practice and discuss kind of the idiosyncrasies that I think had just been raised. And so this is going to be more of like a free-flow conversation where I've got some slides to kind of guide that talk, but please interrupt us and we can go off on tangents because I think we've got, 16 minutes now to kill here. So I am Spencer Payne. I have the esteemed honor of being one of Dr. Catalano's. I'm going to call myself his first fellow, but there was somebody else before me, but we don't talk about him. But I've been at the University of Virginia now for 17 years, and then with me is Mark Dean from the Ear and Sinus Institute in Fort Worth, Texas. I do have clinical research funding for Regeneron, so that's probably pertinent to this discussion. I don't know, Mark, if you've got anything.
I don't have anything for this discussion.
Okay. So I think it is a great topic. I mean, the question is, if Dupixent were free, is there a role for surgery? But the truth is it's not free. And I think there was a great summary where biologics are anywhere from $30,000 to $50,000 per year, and at this point we don't know when or if you can come off of them. What about for our aspirin patients? Aspirin desensitization is $100 per year. So where does that go in the setting of all of this? And then there's the long-term risks, and I think as we do more and more of these biologics in patients, the health, the side effects, the adverse events are going to come out. I mean, we have a handful of patients where we're like, well, I don't know if erythema nodosum was a side effect of this product, but it's odd that it happened the 2 times we tried to start you on it, and so, but if you check the logs, like, that's not a known side effect, and so then we're trying to figure out who and when to use this stuff on patients. And we saw this information on that last presentation as well, where FES is more cost effective. It just truly is. I have these shared decision making with our patients. And what do you say, Mark? Like, let's ignoring all the medicine and surgery that has come to the patient. You're providing the options, and you're discussing biologics. Like, how do you roll out? Hey, there's this shot, but it's $35K a year. And
interesting, my patients aren't they're assuming that their insurance will pay it or other things, which they don't even get into at that point. It's more of that you have to be on it all your life.
Yeah.
That seems to be actually the part that more than cost, because at the end of the day, the patient, if they get on it, they're not paying that. Their insurance company is, and they don't realize that that's what their bill is at the end of the day. It's more of, this is a continual thing you have to be on. And I talked to them a lot about the risk, like as we talked about. I mean, when you start interrupting signaling pathways, it's how many times have we started some sort of new treatment, and then next thing you know, it starts causing cancer or myelomas or something 3, 4, 5 years later because we blocked that entire pathway. We just haven't been on them enough to really see what happens 5, 10, 15 years down the road, and especially as it interacts with all the other biologics, all the other kind of medical problems. And so the one thing I do tell them is, the one thing about surgery is it doesn't always work, but we know we've been doing it long enough that we pretty much know the risk profile of what you're getting into. And that's a lot of times what people like. And I think that it's the unknown of it that makes them a little bit nervous.
Yeah. And then, when they get that initial sticker shock, you know, of the price too. And
Yeah.
I was like, well, no, don't worry. Like, you're not paying for it, but someone is.
Yep.
And so, you know, controversial conversation. What is our role as physician and healthcare provider in looking out for the cost to society? Yeah, Marty.
Well, I mean, that comes in the same point. I mean, I think that they're the same. I think that overall, whether we like it or not, I mean, there's other people that control purse strings and other things, but at the end of the day, as physicians, we're the one that is informing the patient to make a decision both for the cost of the system that'll affect their deductible in 5 years, whether or not we give them a pill that's going to end up causing myeloma because we didn't know it was going to go on, that we were going to cause something, or some sort of polypoid formation later on. I mean, think about x-rays for tonsils. I mean, and adenoids. How many times are people getting radiation for adenoidectomies forever? Because I have one patient that literally the doctor just retired. He's 92 years old, and he's like, I still can't believe we can't do radiation anymore. I'm like, you do know that causes cancer, right? Like, there are risks of things that we do that eventually we find out that aren't smart. And I think that while this may not be as extreme, it's still within that. We're playing with signaling processes within the body that we just don't understand completely, and how they interact with the other drugs they're on and other things. And so when you look at risk, it's either that or a carotid bleed and death. Yeah, that happened then, but is it going to be which one's worse?
Yeah, so Marty, was that like a point counterpoint, or, you know, were you agreeing with me or offering? I wasn't sure. But
No, I think you're saying you're looking out for the patient and what our responsibility was. And I wanted to ask you,
yeah,
what's the best, or what's the safest thing for the patient? It's kind of our responsibility, wasn't necessarily what the choose.
right. And the interesting thing about these studies that look at these qualities is they're incorporating the cost of the expected rate of adverse events into it. So it's not just the straight, like, how much does surgery cost? How much does Dupixent cost? These are also including those side effects, right? And so there's another study that looks at the quality of life impact of oral steroid courses versus FES, which, you know, indicates that if it's 1 or 2 courses of prednisone a year based on the expected